Good afternoon. This is a grand round presentation about malignant hyperthermia. I'm very excited to have the opportunity to present this very interesting topic. My name is Dwayne Miklior. I'm one of the anesthesiologists here at the Marshall Clinic. I do not have any disclosure, and I don't have any financial gain from this presentation. Unfortunately, because otherwise, we'll be early retirement. I'd like to thank my partner, Dr. Dermot O'Neill, and also to Sarah Grassel, RN from Corporate Ed, and Nikki Anderson, our administrator, for helping in developing this MH policy for our system. We have some questions. Hopefully throughout the presentation, you should be able to answer these questions correctly, but let's see how you do before the presentation. What are three things that need to come to the operating room of an MH crisis immediately upon recognition? Then we have the choices A, B, C, and D. If you have the opportunity to answer the question, you can go ahead and answer now. Second question, what is the only treatment option that will save a patient during an MH crisis? And the options are calcium channel blockers, dantrolene, ice packs, and succinylcholine. So you can go ahead and answer the question. I see the polling, it's already available on your screen. That's amazing technology, right? Third question. Let's see, I have to move these a little bit out of the way so I can see it. Who should be contacted immediately if there is a suspicion of a malignant hyperthermia crisis? The options are the provider, the Malignant Hyperthermia Association of United States, Anesthesia, and the patient's family. Okay. Next question. What is the goal time frame for dantrolene to get administered to the patient following recognition of MH? 10 minutes, 5 minutes, 30 minutes, or 15 minutes? Next question. Which is not a malignant hyperthermia trigger? Options are succinylcholine, isoflurane, nitrous oxide, desflurane, and sevoflurane. Next question, final question. Cristiano Ronaldo is a soccer player that plays for. Let's see all those soccer player fans if they can answer these questions. The options are Real Madrid, Juventus, Paris Saint-Germain, and Manchester United. Okay, let's move on. So just a little bit about me, very briefly. I am originally from Quito, Ecuador, and then I came to do my residency in Milwaukee, and then I was looking for jobs, trying to stay in the Midwest and stay here in the Marshall Clinic. Beautiful place to work, and I was appointed as a service line medical director for anesthesiology in 2018. And I have a wife, Maria, 2 kids, Dwayne and Eric, and a grandson, Vance. My time off, I like to play some soccer, tennis, enjoy hunting. I think everybody in this area of Wisconsin has to learn, right? So that way you can use all the advantages of this area. And also, 2 years ago, I got a Harley and like to drive it once in a while. And this is some pictures of, as I said, myself during COVID last year and a half ago, where we did not have a lot of PPE and had to create my own mask with a viral filter that it's usually we use it on our anesthesia machine, kind of customize it. But fortunately now we don't have any problem getting masks or equipment. My kids, my grandson, my wife, the last bow, I got bow hunting just 3 weeks ago, and my soccer team for a few years ago. So the objectives of this lecture is basically present to you about malignant hyperthermia, which is very interesting. It's related with anesthesia. So as an anesthesiologist, you know, having your own pathology that is related with what you do, you know, it's amazing. And it's very interesting to learn about it, to prevent it, and to be ready for it. We'll discuss the management of MH and also our current policy and our cards on the system, because we have to be ready to confront when we have this problem. History, very interesting, very interesting. Back on 1960, people started noticing some patients dying rather quickly during anesthesia or right after receiving anesthesia. At that time, where allophane was used and ether was used, and now we have the newer agents, but it's still the same presentation. And simultaneously in the world, one couple of docs from Australia describe it, and interesting enough, Dr. Locker from Wausau. I have to say that this area, central Wisconsin, is endemic for MH and has the highest rates of MH in the country. And obviously we're known for investigating MH and describing many years ago. Very interesting, when I came to work, I remember in our lounge in the anesthesia department, there was a list of last names because this is, as we will learn, dominant inherited defect that goes from generation to generation. We had a list of last names that somebody in 1960 something started to put on. So that way, every time we recognize a last name on the list, then we ask about MH and things like that. Of course, that wouldn't be possible due to HIPAA regulations and other things. And probably the list is so large now that it wouldn't fit on the wall anyway. We have better ways to find it. And then on the 70s, we started having international presentations about this topic, recognizing other syndromes that were associated with MH. In 1964, Dr. Egger was the first one to publish in a peer journal magazine in JAMA the description of the cases that developed hyperthermia during anesthesia. So temperatures that were super high, rising quickly during anesthesia, and also described what's the hepatic metabolism of allophane and its relationship with MH. Things continued to develop quickly on the 70s, including the description of the end-tidal CO2 rising, which was very important up to these days as well. In Europe, finally, there was the identification of ryanodine receptor gene as being the cause for the MH. I mean, the mutation of the gene was the cause of developing this reaction to anesthetics. And then on the early 2000s, we developed the genetic testing as well. So what is MH. So malignant hyperthermia is a rare inherited muscle abnormality disorder that results from a genetic mutation of the ryanodine receptor. Uh, Interesting enough, this receptor is located at the chromosome 19, and it's um, transmitted generation to generation. The reason why this mutation existed is still obviously is unknown, but somebody presented this mutation and it's still there. Um, it causes a hypermetabolic response when we expose our bodies to a triggering agent, such as inhalational agents, halothane, sevoflurane, desflurane, or succinylcholine, which is the depolarizing muscle relaxant. There is some description of some non-anesthetic things, such as stressors or vigorous exercise that can trigger similar syndrome, but this is very rare. Uh, so what happened is that this problem starts with a really hypermetabolic state after exposure of one of the triggering agents. This related with decrease on calcium reuptake. So basically, there's a calcium accumulation between the cells, and the calcium can increase 500-fold, leading to sustained muscle contraction and developing stimulating glycolysis and extreme heat production. This is, as I said, autosomal dominant with a variable penetrance, meaning that the penetrance is not 100%. So, for example, if a couple, one of the two in the couple, one of the parents has this gene, it will present it on 50% of the offsprings typically. So it is most common on children, and the initial mortality is 70%. But after dantrolene came out, it's now down to 7%. So this is how important it is to know about it, recognize it, and give this medication quickly. Basically, it could be death in minutes. First of all, you notice a high tachycardia, temperature rising, increase of end-tidal CO2, arrhythmias, and cardiac arrest very quickly. But hours later, if the patient makes it at first stage, they can still be on risk of developing pulmonary edema, coagulopathy, and then even later renal failure, nerve, CNS damage, hepatic failure, and multi-organ failure. So it's a very, very severe syndrome or a disease that can be presented. The incidence is about 1 out of 15,000 pediatric cases and 1 out of 50,000 adult cases. So these days, as we do so many surgeries with anesthetic, this is actually high. And in our area, it could be a little higher than this. So asking questions about if the patient had a family history of MH, it's very important. Here in Marshfield Clinic in Marshfield, definitely we see at least a couple of cases that have MH history or family history of MH per month. So there's a lot of precautions that we have to take, to avoid presenting this syndrome, and we're going to talk about it. So as I said previously, MH conference held in Wausau were very important to describe this syndrome, and some of the first deaths that we saw over here, and especially publications about it, was, as it says over here, a 21-year-old patient that came for a fracture. This release of calcium is a mutation on the ryanodine receptor that it's on the membrane of the sarcoplasmic reticulum. we're going to see a picture over here. So over here you can see where the calcium channels are located, and the sarcoplasmic reticulum that has the mutation of the channels that avoid the release of calcium, hence accumulating inside the cell. There is other associations possibly. Now, for this large list, the ones that are 100% associated with MH are the very last one that is called central core disease, and the second one, which is King-Dunborough syndrome. The other ones are very highly associated, and when we have a patient that comes in with all these myopathies, we have to be very cautious and at times even treat it as if the patient had a history of MH with a trigger-free anesthetic. So family history is very important, especially on the peds population. This is a picture of one of our anesthesia machines in our hospital over here. As you can see, we have 3 vaporizers. Those bottles there, the yellow one is sevoflurane, the next one is isoflurane, and the last blue one is desflurane. Those are the ones that are clinically utilized most of the places around the world these days. And when we have a patient that can develop, that is sensitive to malignant hyperthermia, we cannot use this at the point that either we remove them from the machine or use big tape around it and write with a Sharpie on the tape to not use, just in case, let's say you're in the middle of the case and you are relieved for a break and things like that. You have to be very, very cautious on that. So when the exposure can happen, when the disease can happen after you're exposed to anesthetic, usually within 2 hours, but it can last up to 48 hours. So it can happen after surgery. So it's very important to keep monitoring the patients that are sensitive. And the patients that are not sensitive, that suddenly develop, obviously they have to call the hospital if there is a suspicion of that within a couple of days from surgery. What is a trigger-free anesthesia? So as I said, we are going to provide IV anesthesia, most likely propofol IV, and try to avoid those 3 volatile anesthetics that I mentioned. But also we need to flush the machine to try to eliminate any residual presence of gas from prior cases. We need to use special filters on the inspiratory and expiratory limbs of the anesthesia machine to try to minimize that. And usually we've been able to successfully provide anesthesia to patients that had either a documented case of malignant hyperthermia in the past or a documented family history. So some of the clinical presentations we have, we can have a masseter muscle spasm, generalized muscle spasm, heat production due to hypermetabolism, rhabdomyolysis, which can damage the kidneys, tachycardia, acidosis, hypercapnia, hypoxemia, and then lab abnormalities, increase on CK and potassium, that can lead to a cardiac arrhythmia, myoglobinuria as well, and also renal failure. This is a YouTube video. I'm going to play it. I was told, unfortunately, the audio is not optimal. So I'm going to try to play it without audio and try to describe briefly what's happening. Let's see if we can make it happen here. Okay, so basically here you can see in the middle of the operating room, Suddenly, they realized, anesthesiologists, that there's high rate, the end-tidal CO2 is going up, temperature is climbing quickly. The surgeon is concerned. The anesthesiologist is recommending to, oh, wait a minute, I think this is MH, he says. And then they are calling for ICE, they are calling for the MH cart. A lot of help is needed to treat this quickly and control the situation before things get too complicated. And then now they're thinking, oh gosh, yeah, this is MH crisis. Bring me the ice. Yeah, what can we do? This is genetic. Let's talk to the parents if there is a history about it, and just wait and send the patient to ICU, perhaps canceling the operation. So this is one episode of Grey's Anatomy. So isn't that cool? Let's try to get out of here. Back to the presentation. Okay, so this is the link of the video. So if somebody's interested watching, so to watch it with the original audio, yeah, you can go ahead and do it. Or just type Grey's Anatomy Malignant Hyperthermia, and then the video will pop up. The MHOUSE is the Malignant Hyperthermia Association of the United States, and it's what our main reference. It's an awesome site, both for healthcare professionals and for patients and for family members. It explains things, it gives you some videos so you are able to understand. If you have a family history of malignant hyperthermia, get into this website. But most importantly, get tested. Because when you come for a procedure and you need anesthesia, if you say, I have a family history of malignant hyperthermia, I've never been tested, so I'm not 100% sure, we will have to treat you as if you for sure have MH, which that means to us taking all the precautions and using other anesthetics that at times are not the most ideal agents to use. So, you could have an extra risk of anesthesia because we can't use the things that we usually use. I would say that if I was my family member or myself, I will definitely go and get tested to make sure, I said, I have a long family history of MH, but I just went tested and it came negative. So these tests are, especially the genetic test, is very specific. So a negative test, perhaps, it will almost guarantee that you don't have MH. So it will be very helpful. So, so that's it. It's www.mhaus.org. So I encourage to reach to that. So how does this dantrolene work? So dantrolene is definitely a specific treatment for MH. It decreases the release of calcium from the sites that is stored in the muscle, and then also blocks the abnormal release of calcium. So basically, it's sort of calcium channel or blocker, so to speak. So that's why treating arrhythmias or blood pressure with calcium channel blockers, it probably won't be the best agents for when we're using dantrolene. So the side effects of this are significant muscle weakness, especially on patients that had already pre-existing conditions for weakness. It can cause phlebitis on injection, so we need to find usually a large vein. And also it can interact a little bit with hyperkalemia, causing more muscle depression. But hey, this is a life-saving. So, all the side effects are treatable. Still side effects that, can create problem, but, it's a must-use medication because mortality is really high if we don't use it. The caffeine allophane fracture test is the classic test. So basically what this means is that you are going to cut and take a little piece of long muscle, usually in the arm, and then take it right away to a center where they do it. On that center, they cause contraction of the muscle with caffeine or with electrical stimulation, and and they measure the contraction of the muscle, and then after that they expose the muscle to allophane, and they measure the contraction again. The difference of the contraction with allophane is significantly different than without allophane. So basically, it's terrible, more increased contraction, and this will make the diagnosis, which is the gold standard for diagnosing MH. But if it's an invasive test, involves some traveling, a little procedure, and it could be expensive as well. There is just a few centers in the world that do this testing, um, but highly recommended. Now we have the option of doing the genetic test. We're going to move a little bit. This is very interesting. On the MHouse website, you can find the places where they do the muscle biopsy and also the place they do the genetic testing. What do you see different in this list? If you look, these are four centers. One of them is right here in Marshfield. Isn't that something? Prevention Genetics in Marshfield. So you can get tested right here in town. And these are the only four centers in the country that make this test. So I usually give a letter to the patients that have MH and talk to them. And if they were not tested for generations, I think I encourage to do. Very good. Malignant hyperthermia policy. So as our organization is expanding and gaining more hospitals and things like that, it's very important to make sure that in every place where anesthesia is administered, we do have an MH card, we do have an MH policy, and we have the resources to deal with this immediately. So because of that, for standardization, we make the policy. Most of the policy is obviously based upon recommendations from the Malignant Hyperthermia website. But still, with the policy in place, we'll make sure that these are enforced and also that our facilities are ready for confronting a crisis like that. This policy is available as a handout. When you look at this presentation at the website, when you go back, you should be able to click on this and download the handouts. Just a brief review of the handout. So this is it. This is the policy body, and it gives you some definitions. It gives you some names of the medications, and then it tells you what to do roughly when we receive a patient that has MH history. So we do the MH precautions, do the filters and all that. What other machine preparation, as far as I'm talking about the anesthesia machine, we need to do. We need to change the soda lime canisters, absorbents. We need to flush the machine at least for 90 seconds with 10 liters of fresh flow of oxygen or air. We need to change the filters and so on and so forth. All the monitors that we need to have in place, including the temperature, and if the MH crisis happens, how are we going to deal with it? A little description of the medications that we have to do, what it comes on the MH card, the lanyard roles, because it's a team effort. It's like a whole critical situation, so we need to delegate functions to different people on the surgical team, all the interventions. So all that is described on this policy, and even the dosing of the Ryanalex. Something interesting, we're going to talk about that in a little bit. Um, this describes how many vials, how to prepare the vials, diluted with saline or sterile water, and what's the dosing, which things we can find in every drawer, including cooling supplies, because we need to cool down the patient from the bladder, from the esophagus, from at times from rectum, eyes on top, and things like that. So all this is very well described over here. So that will, it's also, you can download this policy from our document library of the system. So let me go back. Okay, good. So we already talked about the malignant hyperthermia things here, site. Also in documents, the handout, this is going to be described, and Sarah did a phenomenal job on instituting this thing. So we had to buy same card because we wanted the card to look closely identical, same number of drawers, same color, and the same cards are available in every Marshall clinic operating rooms or procedure rooms. And this is where they are located. So if somebody wants to check this out, everybody should be aware, every site should be aware where the MH card is located. That's the list over there. This is the policy we already went through. So this is the card. So card standardization, very important to do. So this is what the card looks like. The prevention measures that we discussed about that we need to do when we identify a patient that needs to receive a trigger-free anesthetic. We talked about the several importance of the several signs that are very important, including the end-tidal CO2 measurements and the other non-specific signs and symptoms. We talked about this already. The test on prevention genetics that it's recommended, the genetic test. The differential diagnosis. So all these things can be very obvious at times, but other times not really. So you always have to think about, ruling out sepsis, pheochromocytoma, thyroid storms, iatrogenic overheating, overdose of medications, neuroleptic malignant syndrome, which, by the way, could respond to dantrolene as well. Obviously, sending labs, checking the end-tidal CO2 on the blood gases and all that is very important to help differentiate from all these other syndromes. And that's why the Malignant Hyperthermia Association is very helpful, because you have to contact this right away. First thing you do, this is another answer of the questions. It's called the Malignant Hyperthermia Association of the United States, because they have a hotline 24 hours, and that person has experienced how to deal with it. First of all, we'll confirm the diagnosis with you. It will ask you, what do you have the end-tidal? When did this happen? What's the heart rate? What's the temperature? Blah, blah, blah. What did you give? What did you do? Through the phone. And once the crisis is confirmed, right away to start the treatment. So, and also following up and, send the patient to ICU and all that. So it's very important that, and it's a great tool that we have as clinicians to take care of these patients. So the goal of administering dantrolene is within 10 minutes. That is what's been shown to decrease mortality. So we need to have this, and that's why we have the cards that have dantrolene on it. Talking about dantrolene, there is couple of different kinds of dantrolene. So the dose is, well, anyway, before giving to that, we stop the triggering agent right away. We hyperventilate with 100% oxygen. We prepare the dantrolene. The dose, initial dose is 2.5 milligrams per kilo. Begin the cooling measures, and then treat arrhythmia if needed. Avoid calcium channel blockers. We can use other antiarrhythmics such as procainamide. Secure the blood gases, electrolytes, and other testing. Look at the urine output to protect the kidneys, and then administer the dantrolene. So in our carts, we have one vial of Ryanodex, which is the new dantrolene, and then we have several vials of Rebonto or Dantrium. Why? Because the Ryanodex is very expensive. Each vial costs about $2,900. So yeah, that's what you have in your MH cards. And the other vials are less expensive. They're around about $50 per vial or so, or less. But the other vials, unfortunately, they are powder and they have only 20 milligrams per vial. So, and each of them has to be reconstituted with 60 mLs of sterile water. So you can see why we need people to come in right away to help, diluting, and we need, for 100 kilograms person roughly will need 250 milligrams. So, if we have only 20 milligrams vials, we need a lot of help to diluting all those vials. So that's why having one Ryanodex vial, 250 milligrams right there, ready to go, was necessary to at least get the immediate treatment pronto. And later on, we'll continue with the less expensive dantrolene to continue the treatment to the patient. In the MH cards, we have some resources. We have, by the way, in Cerner, a new power plant for orders when the patient has MH. We do have some documentation that we have to do to report the crisis. We have in every site poster like this that is provided by the Malignant Hyperthermia Society that talks about diagnosis and doses and what to do, how to follow up, how to take care of these arrhythmias, hyperkalemia, and things like that. So very good resources to have. The lanyards that we can distribute to everybody will give to somebody to be the team lead. Another will be the runner that helps bringing things into the room. The other one will be doing the dantrolene. Somebody will be drawing the lab samples, giving the fluids, cooling the patient, etc. So all these cards and charts are available on every MH card. And with this, I want to proceed with the post-test questions. So what are the three things that need to come to the room of an MH crisis immediately upon recognition? And the answer is a cold blue card, MH card, and a cold fluids and ice. What is the only treatment option that will save a patient during an MH crisis? The answer is dantrolene. Who should be contacted immediately if there is suspicion of a malignant hyperthermia crisis? I would say anesthesia, but that's not the right answer. The right answer is the Malignant Hyperthermia Association of the United States. Okay. What is the goal time frame for dantrolene to get administered to the patient following recognition of MH? 10 minutes. Which is not an MH trigger? The answer is nitrous oxide. Nitrous oxide is the only anesthetic gas that doesn't trigger MH. The other three that we use, isoflurane, desflurane, and sevoflurane, can trigger MH. And interesting enough, a different type of medication that we still use, succinylcholine, which is a depolarizing muscle relaxant, can also trigger MH. Everything else does not trigger MH. Every other things that we use in anesthesia, for example, just to name a few, propofol, midazolam, fentanyl, morphine, ketamine, Zofran, antiemetic medications, what else? Precedex, etc. All those things that we use in the anesthesia world do not trigger MH. Cristiano Ronaldo, in my mind, is the best player that we have these days in soccer, the best soccer player, and he plays for, the answer is Manchester United. Although right now they are not playing very well, but they have the best player in my mind. And with that, I will thank you very much for allowing me the opportunity. And this was very limited time, so obviously there were a lot of other things that I would like to talk about MH, but in any case, I think the most important things were covered. In summary, for providers, always suspect about it, ask questions about past family history, be very careful on little kids that are unknown family history, for example, adopted kids. So you have to be very careful on that. And also, once you recognize it, use a trigger-free anesthetic, and also use all the reference tools that you have. Encourage patients to be tested to rule out or rule in this suspicion before they are coming for the procedure. Thank you very much, and please, happy to answer questions. I don't know if Amy has any questions that came through the questions and answer site.
Nope, there are no questions right now.
We'll wait a couple of minutes.
Yeah, one come through the chat.
What was that, Ryan?
There's one in the chat.
Oh, there's one in the chat, Ryan is saying. Are you able to see that, Doctor?
Can you read it for me, please?
Sure.
Yeah.
Thank you.
Amy, do you want to or should I?
I can.
Okay.
Let's see. Oh, actually, there is no actual question in there. Just says, great job, doctor. Thank you. That's from Sarah.
I've got one from Sarah Stresser that says, how long through the family tree do you have to report a family history of MH?
Yes. You always have to mention that that you have somebody in your family tree that had a history of MH. And that's when it becomes really important to get tested to make sure that you have it or you don't. As I said, it has some variable penetrance, so it's not 100% guaranteed that if your father had it, you have it. You may have not. So it's very important to report it and get tested, and very useful information for us. I can remember several times that you're ready to go to surgery, and thanks God, at the last minute, the patient says, "Oh, by the way, yeah, my grandfather, developed some real big problem from anesthesia. I think they call it malignant hyperthermia." Oops, there we go. So we have to look for it. We have always to pay attention on that. Thank you. Anything else?
Looks like that's it on my end. Ryan, you don't have any other questions on your side, do you?